So today we're going to talk about hypothyroidism. So hypo means too little, and then thyroid refers to thyroid hormones. So if we put those together, we have a condition where there is a lack of thyroid hormones. To probably understand this condition, we will first look at the thyroid gland itself and its anatomy and function before explaining what happens when the gland fails. So we will discuss throughout the presentation why this knowledge is important as paramedics, as thyroid disorders are one of the most prevalent endocrine conditions in the community. So now we're just going to talk a bit about the anatomy of the thyroid in order to understand its function. So it is quite a large gland, as you can see on the left, and it produces two hormones, including thyroid hormones and calcitonin. Structurally, it's a butterfly-shaped gland and it's positioned anteriorly in the neck, just below the larynx, where it wraps around the trachea. There are two lateral lobes, so there's a right lobe and a left lobe, and they are connected by a thin bridge called the isthmus. The thyroid gland is also extremely vascular, and it receives its blood supply from both the superior and the inferior thyroid arteries, and it's essentially made of thousands of follicles. So these follicles are lined with follicular cells, and these cells synthesize our hormones T3 and T4. There are also parafollicular cells in the surrounding tissue, and they secrete calcitonin, but that is less relevant for today's discussion. So essentially understanding the location and the structure of the thyroid gland is clinically important, as we can see it's positioned close to our airway. This means that any structural changes such as thyroid enlargement, or what we call goiter, can potentially compromise breathing, and it must be recognised in our pre-hospital assessments. I will go into more detail about this condition later in the presentation. Okay, so now that we've looked at the anatomy, we're going to look at the normal production of thyroid hormones. So endocrine glands do not just release hormones at random. They are in fact tightly regulated by signals. The hypothalamic pituitary thyroid axis, or HPT axis as we're all familiar with, regulates the thyroid gland, and it relies on these signals. So I'm going to explain this process hopefully in a way that we can all understand. So we do have the hypothalamus, which sits at the base of the brain and acts like a sensor. So it detects low levels of thyroid hormones in the blood, and it will release thyroid releasing hormone, or TRH, into the portal system. The portal system connects the hypothalamus to the anterior pituitary, and then this pituitary then responds by releasing thyroid stimulating hormone, or TSH. And we can think of TSH as the thyroid's on switch essentially. So it travels through the blood to the thyroid gland and tells it to start releasing thyroxine and trithyronine into the bloodstream. So most of what is released is actually T4, which is an inactive form, until it's converted into T3 inside cells. And this is what really gets to work and binds to receptors inside the cells to perform the function, which is to speed up the basal metabolic rate. You might be asking, what is the basal metabolic rate? So we're going to explain that now. Okay, so now that we know how these are produced, let's look at what they actually do. So thyroid hormones control how fast all the cells in the body work, which is what we call the basal metabolic rate, or the BMR. They stimulate the sympathetic nervous system, they increase ATP production and oxygen use, and they make sure glucose and fats are broken down for energy. On top of that, they help drive protein synthesis, which is essential for growth and repair. That was a lot of information, so to summarise, T3 and T4 essentially keep the body's energy use and metabolic functions at the right speed, and without them, the body will slow down. So this transitions us nicely into the main topic of discussion for today, and that is hypothyroidism. So now that we know what they do, let's look at what happens when things go wrong. So hypothyroidism is defined as a hypometabolic state, meaning that the body slows down because there is a lack of circulating thyroid hormones. If we link this back to the normal functions that we just learned, you can see why without them, the basal metabolic rate drops, and all the cellular reactions in the body start to happen slower than normal. So let's have a look at the two types of hypothyroidism. So we have primary and secondary. So in primary, our thyroid gland is the issue because it isn't making enough thyroid hormones. And this can happen for a range of reasons. One of the major causes worldwide is iodine deficiency. So we know that iodine is essential for our follicular cells, which we talked about earlier, to synthesize T3 and T4. So without it, these hormones don't get produced. Another major cause is autoimmune disease, such as Hashimoto's disease. This is where the immune system attacks the body's thyroid gland, and this damage leads to cellular hypertrophy and hyperplasia, which is both an increase in size and number of follicular cells as they try to compensate. So other causes include thyroiditis, which is the inflammation of the gland, as well as treatment-related damage like surgery, radioiodine therapy, which damages too many follicular cells, and radiation. For example, a patient being treated for hyperthyroidism with surgery, radioiodine therapy, or radiation may end up with hypothyroidism because too much of the gland is destroyed in the process. Moving on, we've got secondary hypothyroidism, which is where the thyroid gland is healthy, but the issue lies higher up in the HPT axis. So basically, the pituitary or the hypothalamus doesn't produce enough thyroid stimulating hormone, and therefore the thyroid cannot be stimulated or told to release its hormones. This is usually caused by tumours or damage to these higher control centres and results in the same outcome as the primary hypothyroidism. Okay, so we're going to move on to the assessment, diagnosis and treatment. So patients with hypothyroidism will present with a wide range of symptoms and can range from subclinical disease, which is disease that is present without symptoms. So in this context, it would be due to the gradual slowing of the metabolic rate. And they can progress to life-threatening conditions called myxedema coma. So how can paramedics suspect hypothyroidism? We must obtain a detailed patient history and physical examination and perform our primary survey to determine if our patient is stable or unstable. Patients with hypothyroidism will likely present with symptoms suggesting a low basal metabolic rate and sympathetic activity. These symptoms include weight gain despite loss of appetite. We've got fatigue and worsened tolerance to cold due to less heat being produced. We've also got slowed gut activity, so patients may complain of constipation. And we've also got depression, hair loss, and irregular menstrual cycles in women. Our physical exam findings include bradycardia, slow mentation, as well as non-pitting peripheral edema, which is often referred to myxedema. There may also be a palpable goiter, which we mentioned before, which means the thyroid is enlarged due to Hashimoto's disease. Okay, so if our patients present with hypothermia, bradycardia, hyperventilation, and lethargy, we as clinicians should suspect myxedema coma, which is a severe and life-threatening form of hypothyroidism. It's quite rare in practice, but we need to understand it. So it typically affects patients with poorly managed or undiagnosed hypothyroidism, who then undergo like a stress. So we've got surgery, infection, trauma, and these signs and symptoms can often point to other differential conditions, such as sepsis, hypoglycemia, hypothermia from environmental exposure, or a stroke. So how do we rule out these other differentials? So due to their similarities, a diagnosis cannot be made on the clinical features alone. The definitive way to rule out these differentials is with blood tests, and the hospital will rely on combining the clinical features and history that we've gathered with the blood tests to confirm. Okay, just moving back to this slide, so with the signs and symptoms we discussed before, myxedema coma, we should suspect hypothyroidism, but how is it actually diagnosed? So it's confirmed through measuring the blood levels of thyroid stimulating hormone, T3 and T4 hormones, where in all cases T3 and T4 will be low. However, the TSH levels tell us where the problem actually lies. So in primary hypothyroidism, the pituitary increases thyroid stimulating hormones to try and stimulate the unresponsive thyroid. However, in our secondary hypothyroidism, where the issue is in the hypothalamus or the pituitary, not the thyroid, the thyroid stimulating hormones will be low or they'll be normal. So as paramedics, we're not the one ordering thyroid function tests, but we must understand this concept. This is because when we meet patients with a known thyroid disease, it explains why their medication might be adjusted or why they may still be feeling tired, cold, or lethargic, even if they're already on treatment like levothyroxine. So essentially, as paramedics, we must use our clinical judgment to recognise the bigger picture behind the numbers and consider all of the differential diagnoses that come along with this condition. Okay, so moving on to treatment. So the good news is that hypothyroidism is usually very manageable. The main treatment is thyroid hormone replacement therapy, obviously due to our reduced circulating thyroid hormones. And this is usually done with levothyroxine. This is a synthetic form of T4, and once it's in the body, it also gets converted into its active form, T3, which we discussed before, which restores the normal hormonal levels. When this treatment is effective, the patients often notice their symptoms reduce as their metabolism returns to normal. For paramedics, it's really important to remember that many patients in the community are already on this drug. And if they've missed doses or had recent changes, this can cause acute symptom flare-ups.